I'm having a feeling I'm not going to be able to share my screen for some reason. It seems to have changed here on my end.
Okay.
I'm not sure if I should pop out and come back in.
If
It's
you want,
probably because we have a spotlight on right now. You probably just see our logo, Diana.
I don't actually. I just see a logo in the top right, and I see my screen in front. Do you think I'm still? But I don't see how I could share my screen from here.
When I spotlight you,
Yes.
you should be able to see your share screen options down at the bottom.
Okay. Sounds good.
Okay.
All right. Great.
All
Thanks,
right.
girls.
Okay.
Okay.
sure. Good afternoon, everyone. Welcome to the Adelphi New York Statewide Breast Cancer Hotline and Support Programs Forum entitled Breast Relief, a Systematic Approach to Post-Mastectomy Pain. Thank you so much for joining us this afternoon. We have an incredible panel lined up for you. We have a lot to cover, so I'm going to just make one statement regarding this program being recorded. If you would prefer not to be on camera and recorded, I would ask you to please turn off your camera at this time. Also, if you would like to hear the Spanish interpretation feature that we have enabled, please select Spanish at the bottom of your screen as your preferred language and select Mute Original Audio to ensure the best quality possible. Without further ado, I will turn the program over to Nina Foley. Nina?
Thanks, Angela. Good afternoon, everyone. My name is Nina Foley, and I am the Hotline and Volunteer Coordinator of the Adelphi Breast Cancer Program. Thank you for joining us for Breast Release, a systematic approach to post-mastectomy pain forum. As a reminder, our program is open and here to support the breast cancer community. We are offering individual and group counseling over Zoom and the phone, providing workshops and referrals for free and low-cost mammography screenings, and our hotline volunteers continue to speak to people with concerns about breast cancer. Please remember to mute your microphone, and you can choose whether you want to keep your video going. We hope to have a bit of time at the end for questions, which can be asked through using the chat box. If we run out of time, the answers to your questions will be emailed to you. Please complete our evaluation as it helps to provide information that interests you. A link to the evaluation will be in the chat box during the forum, and it will also be emailed to you tomorrow. We are excited to have 3 panelists sharing their knowledge at today's forum. They are Jonathan Bank, MD, David Rosenblum, MD, and Diana Tjaden, PT, DPT. Dr. Jonathan Bank, MD, is a partner at the NYBRA Plastic Surgery. He is a board-certified plastic surgeon with specialty training in microsurgery. His areas of interest include breast and body contouring with the 3-dimensional methodology, breast reconstruction, and reversal of lymphedema. A particular area of interest is sensory restoration of the reconstructed breast. Dr. David Rosenblum is the Director of Pain Medicine at Maimonides Medical Center. He is a leader in the fields of interventional pain medicine and regional anesthesiology. His particular interests include regional anesthesia and ultrasound-guided nerve blocks. He has developed numerous protocols and policies to ensure that the safe proliferation of anesthesia and pain medicine. And finally, last but certainly not least, is Diana Tjaden. She is the founder of the Full Circle Breast Cancer Recovery Program located here in Garden City. This comprehensive individualized program is geared towards every phase of breast cancer recovery. Among its goals are educating women with breast cancer and those recovering from prophylactic reconstructions on ways to regain control over their lives and providing them with the tools they need to return to their prior level of function and reach new fitness goals. This forum is sponsored by the Junior Coalition of the Manhasset Women's Coalition Against Breast Cancer, the Mother Cabrini Health Foundation, and Northwell Health Cancer Center. Thank you all for attending.
Good afternoon, everybody. My name is Jonathan Bank. Thank you for that kind introduction. And thank you to everybody at Adelphi for letting us highlight this program that we put in place really in the height of COVID. And COVID was, well, it's an ongoing issue, but it opened some doors. If you look for lights in dark corners specifically, it gave me some time to put on paper and then in pixels on the internet a thought process that I had for some years now. And it really originated just from listening to my patients and not being pleased with the answers that I was taught to give, particularly regarding pain following mastectomy. In medical school and residency and fellowship, we learn about, oh yes, it can happen every once in a while, something called post-mastectomy pain syndrome. But to me, that's just to say that it can happen and kind of deal with it was not good enough. So during COVID, we sort of had a time to sit and pause and think about how we can systematically approach it and put some paralleling minds together and work in tandem to help address this issue. And I think 1 + 1 makes much more than 2. 1 + 1 plus another one makes much more than 3. And the three of us, myself, David, and Diana, come together to put this program together in which we try to address the issues that women that have had mastectomies or even any other breast surgery that may have affected the sensorium around the breast and chest, and see what we can do to make it better and maybe avoid it altogether. So I'm going to share my screen right now for a second, just to give a brief overview of why we're even talking about this. And then I'm going to let David and Diana highlight their aspects. At the end of this hour, I'm going to talk again about what I do surgically to address these situations and how I want to change how we practice medicine and breast surgery altogether with really this in mind. So I'm going to share my screen. This is a little video that we put together. And this is breast relief. So 1 in 8 women in the United States or across the world will get breast cancer, unfortunately. So there's 3 million women walking around America now having had a mastectomy. About 40% or up to 40% of them have something called post-mastectomy pain syndrome. And that's shooting pain in those 3 specific spots, or can be other spots that cause chronic pain more than 3 months and maybe even longer. So the idea here is to address it with physical therapy, pain management, regional anesthesia, and ultimately reparative surgery if need be. That in a nutshell is what breast relief is. So I'm going to switch back to David now. And I think he's going to go first to describe how pain management really enters the treatment paradigm.
Thank you, Yoni. And thank you all for having me here. It's really an honor to be part of such a team. And I just want to first start by talking a little bit about my practice and let you know we don't only treat breast pain, but of course that's a lot of what I'm doing lately. We treat all sorts of pain problems. We're located in Brooklyn, New York, as well as Great Neck. And we also have satellite offices where other partners are. In the Great Neck office, my partners, Gary Schwartz and Joel Kreitzer, are here as well. A little bit more about myself. I came to Maimonides in 2007 after training at NYU in anesthesiology and pain management. Since then, I've developed the regional anesthesia and chronic pain service at Maimonides Medical Center, as well as my outpatient practice, which is, as I mentioned, in Brooklyn and Great Neck. And we focus a lot on trying to use ultrasound, less radiation than the X-rays, of course, minimizing the need for unnecessary opiates or unnecessary surgeries. I've taught for multiple organizations because I've been very keen and at the forefront of using ultrasound. And that really helps out when you're trying to target peripheral nerves, which are often the nerves that are involved when we're talking about post-mastectomy pain syndrome, not necessarily the spine. And as an aside, when I was in training at NYU, I developed a board review for other pain doctors. And I use this platform to grow basically a small audience of pain doctors who I reach on my podcast, and I try to give them updates as to the latest and what's going on in pain management. In fact, I've done a couple of podcasts on post-mastectomy syndrome, pain syndrome. And if you just go to the iTunes store for Pain Exam Podcast, you'll probably find it. In addition, I've written a few textbooks chapters and have been at the forefront of regenerative medicine and taught some courses on that. And this is all relevant because of this. These are part of the tools in our arsenal when it comes to treating chronic pain. No two pain patients or post-mastectomy pain patients are actually the same. They may have different features of the syndrome, and they may respond to different therapies. So in the last, let's say 10, 12 years, the biggest advances in pain management were probably in the field of regenerative medicine, meaning PRP or platelet-rich plasma, bone marrow aspirate. Some people refer to that as stem cells, but we really don't call it that. Neuromodulation, which involves using electricity on nerves to alleviate symptoms, and the use of ultrasound to guide these therapies in real time. But with all that technological advancements, I still focus on preventative care, diet, exercise, psychological and physical well-being. Patients, of course, need to have a good support structure, whether it's family members or friends. And they also need to think about prevention as much as treatment of the current pain syndrome. And that goes with an anti-inflammatory diet, avoiding foods that can cause inflammation or other problems with health, avoidance of smoking. Smoking isn't only dangerous because of lung cancer and heart disease, but it causes an inflammation of the blood vessels. Lack of blood flow can occur secondary to this, and some of the tissues may not be getting so much blood flow to begin with, and this is especially true for joints and the discs in the spine, but in general, poor blood flow can contribute to degeneration and further pain. So as Dr. Bank alluded to, post-mastectomy syndrome, it will often happen after a surgery. It doesn't have to be mastectomy, it can be lumpectomy, lymph node dissection, or any reconstruction. It can be in different locations, and it's not a specific diagnosis. So it's typically occurring 3 months after a surgery, and the incidence in some cases can be as high as 40 to 50%. And as you can see here, it's not just one physician or therapist treating the problem. It's usually a team that includes the physician, the physical therapist, maybe psychologist, surgeon, etc. There can be a neuropathic type pain, which means a pain related to nerve irritation, which is a burning, tingling, or aching pain. There could be some sort of tightness around the chest wall. There can be a phantom breast or nipple pain, meaning the nipple may not be there and you may feel it, but it may be painful. Some patients will describe the iron bra type sensation or a heaviness of the breasts. And the neuropathic pain can be a result of surgery or radiation or the chemotherapeutic agents. Neuromas are what can happen after a nerve gets traumatized. The nerve basically can be more tender or inflamed or swollen. It can occur with transection, meaning a cut of the nerve. And it can occur at different nerves. It could be the intercostal nerve, which are the nerves that run between our ribs, or the thoracodorsal nerve, the pectoral nerves, and the costobrachial nerve. The lateral cutaneous nerve of the second intercostal nerve is the intercostal brachial nerve, And this supplies sensation to the medial aspect of the upper arm, axilla, and lateral chest. This can be cut during an axillary lymph node dissection, and this can result in paresthesias, which are basically like pins and needles and shooting pain down the arm. And it's a very common nerve to be irritated during mastectomy. It's not, or lymph node dissection is not the only one, though. There are other nerves in the region, and you can see all sorts of other consequences that can occur. There can be also swelling causing pain. There can just be trigger points. The muscles can become spastic, and they may need to either massage or a trigger point injection. You could also have shoulder issues or nerve issues. The brachial plexus is a group of nerves that runs down the arm. And you could have injuries to these regions, and this could lead to disuse and further injuries of the shoulder. Sometimes patients will come after a mastectomy and they'll have neck pain or shoulder pain, not even the typical post-mastectomy pain problems that we see. And I have to address these other complaints, and I'll be doing shots that really are not what you kind of categorize a primary treatment for post-mastectomy pain syndrome. However, no two patients are the same, and the pain in one area can affect another part of the body and lead to other problems. The tissue can become adhered to the chest wall. There could be dysfunction as to the movement of the scapula along the thorax. The pectoralis muscles may have issues as well. And this all influences the other tissues in the region, such as the shoulders and the rotator cuff. Risk factors are multifactorial for post-mastectomy pain syndrome. And the patients who typically have more postoperative pain will be at a higher risk, as well as those who've had multiple surgeries. Younger patients typically are more sensitive to nerve damage, and I see this quite a bit with all sorts of problems in my practice, not just post-mastectomy pain syndrome. They also may have higher anxiety, and they may need more aggressive treatment. Psychological factors are always part of this. Depression, anxiety can amplify pain, and the pain can amplify depression and anxiety, catastrophizing as well. So there's a lot of interplay between the central nervous system, the psychology of this, as well as the actual pain. So the treatment, I think Diana could really talk more about the rehabilitative interventions and the exercises more than I can. But when it comes to medications, I try to stay away from drugs whenever possible, but typically we might give something for neuropathic pain. You may have heard of drugs such as gabapentin or Lyrica. Sometimes antidepressants are administered in my practice, not for depression, but they also treat nerve pain, and they sometimes help patients sleep. One of the side effects of the tricyclic antidepressants is sedation, and it can help with nighttime symptoms of pain and help the patient sleep. And of course, there's the injections, and I do have some slides coming up on the injections, but I'm not going to really focus a lot on them. They're not really meant for patients, and more meant for physicians. But still, when we do give nerve blocks, there may be some sort of anti-inflammatory effects from drugs like lidocaine. Lidocaine basically is a local anesthetic. It lasts an hour or two, but sometimes they'll give a shot and the patients will either have a resolution of their symptoms or they'll get weeks of pain relief. And the act of injecting this drug may give the long-term relief, because what you're doing is you're actually doing a hydrodissection. You may be breaking up adhesion, something that a massage or physical therapy can do. Sometimes we're doing it pharmacologically with an injection, and that alleviates symptoms. There are nerve blocks that we do for patients. There are nerves that go between the pectoral muscles over here, in which we'll target the nerve with an ultrasound, and we'll turn off this region. We can inject the local anesthetic with or without steroid, sometimes a biologic such as platelet-rich plasma, which doesn't really have a strong history when it comes to treating post-mastectomy pain syndrome. However, it is becoming more and more popular, and I believe the insurances will start to reimburse for biologics such as platelet-rich plasma because it's safe and it's effective for many different pain problems. There's lots of studies proving that right now. Haven't seen much when it comes to post-mastectomy pain syndrome, but hopefully there'll be some in the future. We're also doing all sorts of the trigger points as well as nerve blocks. And when it comes to nerves, we are doing procedures that stimulate the nerve to reduce pain, and they're shown to be successful and safe in many patients. And this is just a couple of images of the nerves that we're targeting. I'm not going to spend too much time on these because I know the other speakers need to talk. Of note, the intercostal nerve block is a group of nerves that have also been implicated in post-mastectomy pain syndrome. And we were blocking these nerves for over 100 years, but now we're able to actually see these nerves in real time with the ultrasound and block them. In rare cases, usually it's a palliative case, we're able to alleviate pain from these nerves by injecting substances that are much stronger and give a longer duration of time, such as alcohol or something called phenol. And just to skip to the end, I don't know if I have, sorry about all these. These are mainly for the physicians, but I just wanted to give you my office information. And you can find us in Great Neck. My partners, Joel Kreitzer and Gary Schwartz, help me with this practice. And we try to avoid using the cookie cutter approach to medicine because when it comes to pain, no two patients are the same. Thank you. I'm going to stop my share, Yoni.
Okay. Are you able to see my presentation here? How's that?
Not yet, Diana.
Not yet.
In the meantime, if anyone has any questions, I can help. I can answer, or I can answer afterwards via email.
All right, let's see.
I have a question here. If it's okay, I'm going to answer it while you're working on that.
Yes, please do.
Okay, so the question is, what about pain from lymph node dissection? I'm a year out and still have discomfort with both sides, left breast mastectomy, right breast reduction, and lift same and right side lift. So when it comes to pain, if the pain is in the region of the lymph node dissection, is the pain going down the arm or it's just in the armpit? It really depends. If the pain is radiating all the way down the arm, there are nerves that we target for that. If it's localized in the armpit, you may respond to a local injection of local anesthetic or maybe a topical cream. We sometimes use lidocaine creams or anti-inflammatory creams. It really depends on the situation, exactly where your pain is. But generally speaking, we try to start with least invasive and slowly crank it up a notch as need be. Hope that answers your question.
Thank you, Dr. Rosenblum.
Thank you.
Okay. Sorry, guys. I had it before. All right. All right. No, it's not letting me share this.
There you go.
I'm not seeing my presentation though.
It's right on the top, Diana, to the left. a
There?
little bit. There you go.
Okay. There
And
we
on the bottom right, there's, yeah, click on that.
go. Okay. All right. Here we are.
Great.
All right. Thank you so much. I'm so excited, and I become more and more excited about this topic as I know Dr. Bank and I know we have two really great people on here, Jennifer and Carolyn. And my name is Diana Tjaden. I have recently partnered with Ivy Rehab. I've had my own practice, Full Circle, for over 10 years. And we exclusively treat patients recovering from breast cancer. And when Dr. Bank asked me to be a part of this, I get more excited about it every time because we're changing people's lives. And it's very, very cool. So thank you everyone for Adelphi for allowing us to share this. I know that Dr. Rosenblum just covered a lot of this, so that makes it easier with what exactly this post-mastectomy pain, post-breast surgery pain symptoms are, and these are the possible contributions, all that he spoke about. So breast relief Dr. Banks going to speak more, but what we do is the systematic approach is that you would come to therapy. If your pain is not resolved, then we would refer you to pain management, and then we would, Dr. Bank would see you for reparative surgery, and we'll be talking more about that. So that's the way it typically goes. Okay, so my role is physical therapy. I like to think of it as two pieces, a physical piece, and then we have the emotional piece. Physically, preoperatively, we love to see people to address pre-existing musculoskeletal problems, shoulder, neck, or back pain, provide education. But I have to say, more importantly, is early post-op. That is really has been the key. That's where we have the ability to restore range of motion, tissue mobility, flexibility, strength, educate, and it all comes down to the early intervention being to understand this time frame, because that's when we are able to intervene and to refer if we need, if things are not going according to plan. So now I love a couple of these next slides, because it really drives home the amount of muscles that are impacted by these surgeries. Whenever our patients come to us, and over the years we work with amazing doctors, and aesthetically people look incredible, but the magnitude of these surgeries make us understand why people run into a lot of these problems. So now the muscle groups that we address as physical therapists anteriorly, we deal a lot with the pec major and the pec minor. On top, you have the pec major. Below that is the pec minor, and that's a muscle group that is below the pec that actually attaches to the shoulder blade. Now, they've come so far in regards to the surgeries, where you see the picture to the top right is the pre-pectoral surgery, which is done often now, which is incredible in a lot of ways. But there are a lot of sutures that still take place in that area. Then we have the older and the more traditional, which still is done often and is great in a lot of different ways, below the muscle. So that directly impacts the pec. So in a physical therapy setting, the bigger pieces to this is to understand that when people are having an expander, an implant, even tissue that compresses that area on the chest wall, oftentimes it changes the mechanics of the shoulder blade, because we have the chest as it attaches to the shoulder blade. And what happens is you have some anterior tipping of the shoulder, some faulty mechanics. It decreases the space for the rotator cuff tendons to maneuver below within the shoulder blade when people are reaching out to the side, overhead. And oftentimes what we see is patients come in and they have shoulder pain, start of adhesive capsulitis, neck discomfort, lots of different things like that. Now, the muscles that we see that are typically indirectly affected are all these muscle groups around the shoulder and into the back region. We have the serratus, we have the latissimus, and the trapezius muscles. All of these muscles in the front and back contribute to muscle imbalances. And we love to address muscle imbalances. That's really what we do best. We see a lot of muscles tight anterior, weak posterior, and we work on those and we're able to restore somebody's function. Now, this is a bigger piece of what we saw, especially during the pandemic. Everybody comes in with poor posture. That's where we all start. And over the course of the pandemic, we had done a lot of telehealth, and it was really an eye-opener to see how tight and what position everyone was putting themselves in on a daily basis. Now, this is Lily, one of our patients, and she was so kind to give us these pictures. But what she came in with was a lot of tightness anterior. She actually had a deep flap. And when people come in with tightness, the tightness after these surgeries is magnified. It's just what happens. So what we worked on was a lot of stretching and tissue manipulation, soft tissue mobilization and strengthening. And then after that, that's what Lily looked like. Her arms were up over her head. Because if there's a lot of tightness anterior, patients are flexed at the trunk and they're unable to bring their arms up over the head. So we work a lot on these muscle imbalances. As for the emotional piece, we all understand as a healthcare practitioners taking care of everybody, the magnitude of these surgeries. And I think that a lot of times people think it's going to come to an end, but unfortunately there's a lot of joint pain. There's a lot of, there are many more surgeries than people expect, and people are struggling. So It's very important for us to identify and to see people early so that we can break this cycle. And what it typically looks like is people have pain that leads to decreased movement, that then leads to decreased activity. And that's a lot of times because people just don't understand if they should be moving or how they should be moving or what they should be experiencing. This could lead to weight gain and it could lead to depression, so that our job is then to break that cycle. So in summary, education really is power. Physical therapy pre-surgically for pre-existing muscle imbalance and strength deficits, post-surgically to restore range of motion, flexibility, tissue mobility, and strength. You know, a lot of times patients come in and they are having a lot of pain, but we understand that they're going to have a lot of pain. They have a lot of muscles that are impacted, but we have the opportunity when we see them to tell them that that's normal. You have burning throughout your chest after surgery. What you can do is try to desensitize that area. We are able to give them some tools to allow them to understand this time frame of healing. And when they get sharp shooting pains throughout their breasts 3 to 5 weeks after surgery, the nerves are regenerating. We know this is all normal. So we have the ability to share that with them. The biggest piece becomes when we have the ability then to refer them to someone in conjunction with us, like Dr. Rosenblum for pain management, when something's not going right. And after doing this, it becomes very obvious when Dr. Bank has educated us as well about some of the different areas and why these things happen. It becomes very obvious that something else can take place in conjunction with therapy to push them along. And then we know they go see Dr. Bank, and some very cool things have been happening lately. And I'm more excited to hear him talk about that. Thank you.
Thanks so much, Diana.
Thank you, David and Diana. We really couldn't do any of this without a team approach. And what I started saying earlier, that COVID not just gave us the time to think about this, but also gave us the time to do what we're doing exactly now and get together a bunch of people and consult and talk to a person that may be elsewhere that couldn't come to the office because of COVID, but has now the opportunity with telemedicine to really meet with 3 different practitioners at the same time, get the same stories, save yourself a trip between various offices that may not be the right starting point. So we actually have a lady here in the crowd, a couple that was one of our first women to sort of partake in this process, and she's now on the other side, and we'll get to that in a couple minutes. I'm going to share my screen again. That's basically the introduction to what breast relief is. 3 different disciplines coming together to figure out how to solve this problem. I'm going to show some clips of what I do. I'm a plastic surgeon. I primarily do breast reconstruction. This is an example of a deep flap. So we transplanted tissue from the lady's lower belly to reconstruct her breast. So what you see on the right are not real breasts. They're reconstructed breasts, reconstructed nipples, and a bit of a benefit. This is another woman who came to me after having had no breast reconstruction, just dealing with her cancer. And then in a couple of stages, we reconstructed her breast. Now, I always show this picture when I talk about delayed breast reconstruction, and this is what it's all about. It's not about the breast. It's not about the nipples, the symmetry. It's about this smile at the end of the day, which is physical in parts, but it's emotional in parts. And as Diana just pointed, they're all interconnected. So a nice breast reconstruction is worthless if the person is in chronic pain, can't do activities of daily life, and just can't find a comfortable spot. So that's where I feel like we need to change the game. So back to the basic anatomy. There are several nerves that wrap around the breast tissue or the breast skin envelope. They come from the sides, they come from within, and there are additional ones from top and bottom. Those are ones that are frequently affected during surgery, particularly ones on the outer side and sometimes on the inner side of the breast. And on occasion, when lymph nodes are involved, then maybe in the armpit area. And on an even rarer occasions, one that sort of come down from the lower part of the clavicle and towards the upper part of the chest. So I became very interested in those nerves as part of my breast reconstruction practice. During a mastectomy, some of those nerves are cut. And what I do as part of the deep flap reconstruction, in which we take tissue from the lower abdomen and we transplant it to the breast. So this is an example of a bilateral breast reconstruction where we harvest the fat and some of the skin from the lower belly. We preserve the blood vessels, highlighted in red and green here, and then reconnect them to the ones in the chest. We also can cut a nerve from the belly because that's going to be cut anyway. We reconnect it to a little cable graft that gives us a bit more length. That's what you can see in the white over there. And then we transfer it at the time of the mastectomy or later on to the chest. We reconnect the blood vessels to blood vessels in the chest. And what I've been doing in order to try to restore sensation is I reconnect the nerves to the ones that used to go to the breast that are cut during the mastectomy. And nerves outside of the brain and spinal cord want to grow back. They grow back at about a pace of 1 millimeter a day. And that could potentially restore sensation to the skin and the nipple. That's a good thing, but that's also a problem because nerves that are stuck in scar tissue or other mechanical obstructions aren't able to grow back. This is an example of a woman that had breast reconstruction, and I'm showing here later, about a year later. How do you feel?
Good.
She feels sensation on that patch of skin that actually came from the belly, and that's not a real nipple, that's a reconstructed nipple. In a previous film of her, I actually showed that there's no sensation right at the nipple area, and it grew back over time. And I think it's primarily because we reconnected those nerves. The problem is what happens when you don't connect the nerves, or if there's something that's obstructing them. And the common complaints are here in those blue spots on the outer part, inner part, and the armpit area. And those are the areas that we were trying to reconnect the nerves. So this is a lady that had implant reconstruction elsewhere, complained, wasn't happy with the shape or the size, and said she had this, by the way, I have this spot of pain right in my armpit area. Well, and it affected this whole outer region of her left chest. She had implants that we removed. I found a nerve that was cut and filled or surrounded by scar tissue and even a metal clip that I'll show you right now. That's a spot that hurt her on exam, like she touched it there and we jumped to the sky. And then if you can see right in the middle of the screen, there's that little spaghetti looking thing. It's kind of hard to see. It looks like it's really searching for a one strand of spaghetti and bolognese sauce in a bowl of spaghetti. But you can see right next to that nerve are these little clips, little metal clips that were occluding the nerve. They were occluding the nerve because they were right next to blood vessels that bled during her first operation. So I took tissue from her inner thigh this time because she already had a tummy tuck. We couldn't use the fat from her belly. I removed that tissue, the blood vessels, and the nerve from that area. And then I transplanted it to the chest. I know it looks like a flying slice of pizza. It's not. And reconnected those blood vessels just like we do with the abdominal operation. This is called a tug flap. And I reconnected the nerve and with a special nerve connector and so on. And we went on to a full recovery and literally woke up from surgery to say, I don't have that pain anymore. I feel sore from having surgery, but that pain is gone. And she's back to working full-time as a nurse and really having no issues. And so this is like a bit of a before and then after, before she completed reconstruction, making the nipples. This is one of my favorite ladies of recent. This is Jen. This is a picture she sent me this morning.
5 years ago when I started this, right from my first surgery, I knew that there was something different. I couldn't put my fingers on it. I've been in physical therapy for 5 years. And every time I would raise my arm, I would get this incredible heat, numbness. The pain would start all in here. I just figured it was healing all in here. I would be able to touch a spot over here that would send me through the roof.
So same thing, we went in, we found exactly in the area that she was complaining of pain. You can see that kind of blue mark where my finger is pointing. Right at that spot, internally, I found the nerve. Again, it looks at like that little yellow spaghetti noodle that I'm highlighting right now. And it was going right into scar, and it was right next to a permanent stitch that her previous surgeon placed. So we released that. And then we basically just rerouted that nerve to a safe spot, a safe, healthy spot with no scar tissue.
Came to you, and
This is what happened.
I don't feel like two separate people. I used to say that my left side, I was one person, my right side, I was a different. And I don't feel like that. And it's crazy because I really didn't believe that that could really happen, and it did. And I'm very excited. And I'm only 2 weeks in, so we'll see what happens 4 weeks in, 6 weeks in.
Okay, so this is Tjaden, week 3, doing a long layer haircut that she has not been able to do in years. She's able to extend her arms up and cut without numbness, without pain. No numbness. So far.
Thanks for Jen for letting. So again, it's really I can't do this alone. We can't operate without a group. Physical therapy is a huge component. A lot of times it's helpful, like Diana said, most immediately after surgery to really prevent scar tissue from forming and to retain mobility, or else you just end up going down this vicious cycle, and it's a problem. So immediately after these operations, I send them right back to Diana to just keep moving, keep going forward. David enters the picture where physical therapy sort of maxed out, and you might be giving pain medications in the most sort of economical and safe way. And then you would move on to more invasive things like injections and so on. I really only get into the picture where that's it, we're done, and we need to go back and operate. That together is what we call breast relief. And honestly, I do all different kinds of breast reconstruction, other cosmetic cases and so on. And I can honestly say that this has really been the happiest part of my career thus far. You come in women that are just miserable and in chronic pain and don't know where to put themselves. And I know frequently that there's a specific spot, a mechanical problem that turns into a physiologic problem, that turns into a psychological issue. And it's literally been, I don't want to say jinx myself with the numbers, but there really haven't been instances we haven't been able to help women to a tremendous degree. Nothing is perfect in this world. There could be spots that still hurt. We still need Diana. We still need David. Your jobs are safe. But I think we can definitely help a lot of women out there that are suffering, and more so. And what I've been trying to do to educate my colleagues and my breast surgeons that I work with that are open to listening is say, just be mindful of those nerves. They look like little spaghetti noodles. But there's nothing better than a nice juicy piece of spaghetti. So don't damage it. And be respectful of the anatomy, and try to avoid a problem if you can. And if we can avoid a problem, because some of the nerves do get cut, then we have to figure out how to manage them during surgery. And there are different modalities that I apply during surgery for prevention that are extensions of the techniques that I use and the approach that I use in repair. So I think thinking about this topic, talking about this topic, telling your surgeon, wait, what about the nerves that are going to be cut? Don't be satisfied, but yeah, that can happen sometimes. Because even if it happens in just 2% of the patients or 8% of the patients, that's a lot of patients. And if it's just the one individual that can't find a comfortable spot and wants to blow their brains out, then we're not doing a good enough job. So forums like this that get the word out are going to push the needle. Just how many people? 40 participants at a time. And the more we talk about it, the word is going to spread, and we're going to do better for our patients, for our loved ones, for our wives, for our grandmothers, for our daughters, for our sisters. And again, I appreciate so much the opportunity to discuss this. Angela, Carrie, and my partners in, well, reversal of crime, Diana, David, and thank you all for listening. I'm really open to answering any questions now or at any other point in time.
Thank you so much, Dr. Bank, for that incredible presentation. And we do have a question in the chat. Stephanie is asking about irradiated breast. How can that pain be managed?
Yeah, radiation is really throws a wrench in everything potentially. Not all radiation is the same. Some women are affected, or men are affected to a more severe degree than others. Sometimes it depends on the protocols that are used. Sometimes it just depends on how one reacted to the treatment. Radiation, well, it really, from my standpoint, it really does a number on the microscopic blood vessels, not the ones that I showed, the red and blue ones, the tiny ones that you can't really see, that are in the skin, that are in the tissues, that are in the breast tissue, that are in the chest muscle, that are in the ribs, and are in the really every component of that whole architecture of the chest wall. And that affects how things heal. It affects how pliable, how mobile, how elastic the tissues are. And it really compounds everything. I have many patients that have had radiation that have really no specific pain issues. I have some that kind of have a general achiness, and that's what I would attribute it to. And then there are others that have had implants placed underneath the muscle. The muscle now becomes much more sort of rigorous, much less pliable. So it compounds the tightness that women feel after reconstruction with implants underneath the muscle. So I think a really good way to treat that is just to remove the implant from underneath the muscle and then replace it either with another implant above the muscle, which is a very common procedure in my practice these days, or to replace it with natural tissue from the inner thigh, from the lower abdomen, from the back, sometimes to just get rid of as much radiated tissue we can and replace it with soft, non-radiated tissue that has its own blood supply. So radiation, in short, is a bit more of a complex issue, but can most definitely be addressed. I have a lady that was treated at one of the biggest cancer institutions, and they said, "Nah, you know, that just live with it." Not an acceptable answer. And we just recently did that tug flap, the tissue from the inner thigh, and while things aren't looking perfect just yet in terms of the aesthetics of it, she's like a different person. I'd show her video, but she speaks Portuguese only, so it'll be less effective to most of our audience probably.
Could I chime in for a second on this topic here? We see a lot of patients after radiation, and it can be years after. And the tissue extensibility really changes. And I think that if patients haven't had therapy and the tissue addressed in very specific ways, that can definitely be an option regardless of when. Of course, it's much easier to address after radiation has ended, but there are very specific regions that we see every day that are tight throughout the pec, lateral rib cage, shoulder blade. And we really make a really nice difference in the patients when we're able to lengthen the tissue and give it better tissue mobility and really restore some of those impairments. So I really feel very strongly that that's definitely something to be addressed. I think people don't realize that they're lacking motion until somebody works on the tissue and then they have better motion, because we really see that all the time.
There's a question, is it too late if my surgery was 4 years ago? Absolutely not. A lot of women that we take care of have had mastectomies several years ago. You know, it could be 1, 2, or maybe even longer. I think there might be somebody here that's been out for further that we dealt with this. So the most important thing is for me to approach that is to really try to identify a spot on physical exam and taking a good history, and trying to understand if there's a specific point that we can target. I think that's where that's where the surgical option really comes into play. But as a test, sometimes we inject some numbing medicine just then and there in the office to that spot. And if we can, and frequently within minutes, that pain will go away. So it's sometimes that stops that whole vicious cycle, and sometimes it just sort of tells us where to look. So if we can find a spot 4 years later, or if there are other things going on that may be able to be addressed, then surgery may be an option. But again, I would always start with physical therapy, making sure there is nothing that we need to do from a pain management standpoint. And then the last resort is surgery.
Thank you. Okay, we have another minute. If there are any other questions, I would invite you to write them into the chat. If not, we can certainly forward the questions to the individual practitioners. We have one. What are your thoughts about silicone implants? If someone who has an Allergan round that does not look like a typical breast, and it looks like she was not a candidate for the flap because there was not enough fat and tissue available.
Okay. Implants over time change a little bit. They never fully incorporate into the body because they're not natural tissue, and no blood supply can grow into them. So what the body does, it shells the implants like it does any foreign object that would enter into the body. Wants to shell it away, creates scar tissue around the implant. That's called a capsule. Not infrequently over time, that capsule that initially is just kind of there, it takes on a little mind of its own, and it can contract, it can shrink and cause warping of the shape of the breast. Sometimes that's painful. When radiation's in the mix, it's ubiquitous, and it's even more painful and more severe and very hard to deal with. So how does one deal with it? If it's an issue that it's causing pain that's severe enough to sort of warrant surgery, or just a contour issue that the woman is not pleased with, then we definitely can address that. A lot of times we'll remove the capsule if it's really hardened and problematic. We may upgrade the implants to sort of newer versions. There's some implants that have been removed from the market because of a certain texturing in their capsule, that in the outer shell of the implant, not the capsule, that has been associated with other medical problems. We don't use, I never have, but they're out there. And if they're causing a problem, they should be removed. So we'll remove them and replace them either with a fresh implant or with the flap tissue. Saying that there's not enough fat, I don't always agree with that statement without examining the patient, because I think that there are ways to capture more fat than one thinks that one has if you're sort of adept at those techniques. And the last option is, well, not the last, but the third one that I'll mention is combining flaps with implants. Performing a breast reconstruction with a little bit of this and a little bit of that is sometimes a lot better than performing a whole breast reconstruction with just an implant. So a lot of times we'll do something called a hybrid reconstruction, where we'll take fat from the inner thigh, the back, the lower belly, knowing that it's not enough to get to the volume that we want, and then we'll supplement it either with fat from elsewhere with a slightly different technique, or we'll put a little implant underneath that fatty tissue. And then that becomes much more like a breast augmentation with a small implant under natural healthy breast tissue, versus an entire breast reconstruction with an implant in which there's a thin layer of skin, maybe a thin layer of natural fat underneath the skin, and then a silicone implant, which a lot of times doesn't feel the most natural, comfortable, warm, and so on. So that combination is really increasing in popularity. We're doing it in fairly large numbers, and it's shown to be very, very safe. So I like that option, even in the face of radiation and all different kinds of other constellations. So.
Thank you so much, Dr. Benkin. One last question just to wrap up. This is an important one. What is the typical time frame for someone when they are having physical therapy? Is there a standard prognosis or standard time frame?
So oftentimes patients come in usually 3 to 4 weeks after surgery. That's clearance from the plastic surgeon. Typically a little bit earlier when they have the expanders or implants, sometimes a little bit later with the deep flaps, but that's definitely the plastic surgeon's call. That's when they really start to become a little bit more mobile anyway, about 3 to 4 weeks after. Everyone's moving a little bit better. And people tend to be with us. It can be anywhere from a couple of visits, or people tend to be with us for several months. Sometimes we see people throughout the course of a year, depending upon if they have radiation, chemotherapy, a revision surgery, the next phase. So we've had people for a long time. So I feel like we try to make it very individual. We like to regain everybody's mobility and strength. There's a lot of obligations people have in general, a lot of appointments. So it's very individual based. But when people have expanders in, it's usually over the course of that time frame. So that's usually within a couple of months. And then sometimes they come back after that surgery if they need it.
Thank you, Diana.
There's one other question, thoughts on acupuncture?
I think the breast pain and post-surgical pain is a multifactorial problem frequently. I trained in Western medicine. I'm not adept in alternative options, but because of that, I'm not willing to knock them. And I really think that a lot of people benefited from acupuncture for reasons I can't personally explain, but doesn't mean that it doesn't work. So I think that that's fine. I think that it's definitely worth trying before one ends up under my knife. But I want to just end with saying that post-surgical or post-mastectomy breast pain, particularly in the context of a history of breast reconstruction, the number one thing to make sure is that the pain isn't related to something else. So follow up with the breast surgeon, follow up with the medical oncologist, imaging studies, biopsies if needed, just to make sure that there's not a medical problem, an oncological problem before you go spending time on acupuncture, and then if that doesn't help, find yourself months down the road and maybe behind the 8 ball. So I'm not knocking it, but I must say that it has to be placed in the context of safe medicine, and I think it's a great adjunct to all things that I do understand a little bit better.
Thank you so much, Dr. Bank. Does anyone have any other questions before we wrap up? You put them in the chat. Okay. So I want to thank Dr. Bank, Dr. Rosenblum, and Diana Tjaden. We are very grateful for your presentation, and we want to thank everyone who showed up today. Please remember to fill out the evaluation, as it helps us to provide you with whatever you're interested in seeing in the future. And don't forget that we're here to support you, and that we're providing free services remotely for now, both on Zoom and by phone. So thank you, everyone.
Thank you, everybody.
Thank you. Good night.